Tonight's presentation will include topics that may trigger an emotional reaction. Faculty and staff from the Counseling Center are available if you need support during or after the presentation, and they're located in the back left corner. Well, my left. The Counseling Center is located in Rhodes Hall and is free to all students. We encourage you to take advantage of this resource on campus if needed. Our speaker tonight is Ivy Shorts. She is a current student at Teal College and also the president of her campus's Active Minds Club. Ivy speaks on her experiences with having an eating disorder and what recovery is like for her. Please join me in welcoming Ivy.
Thank you so much. It's an honor to be here tonight. Can everyone hear me okay? All right. I'd like to begin by talking about recovery. I'd like to take a moment to break this word down. Each letter has a different meaning. R is for realizing that you are worth it. E is for experiencing true happiness. C is for caring about yourself. O is for overcoming your own demons. V is for validating your own worth. The second E stands for eating without regret. The second R is for relapse. It's inevitable, and that's okay. Before I finish up with the why, I'd like to take a moment to explain why relapse is a part of recovery. Dr. Karen Bello has given some very wise words about this subject. They say it takes, on average, 7 tries to quit smoking. If someone fails on their 6th attempt, it does not mean they're a failure. It just means they haven't hit that 7th mark yet. Recovering from eating disorders is like that. Missing the mark once doesn't make you a failure. Slipping repeatedly doesn't mean you're helpless. It just means you haven't tried enough times yet. And personally, that was one of the hardest things for me to get over. I'm definitely an all-or-nothing thinker. It's black or white, no gray areas. My recovery was not exempt from this. If I had a slip, I immediately wrote it off as a failure, and then boom, that slip turned into a full-blown relapse. My treatment team has been very diligent to remind me that relapse is a part of recovery. It sucks, but it's something I have learned to accept. Now, the why of recovery. Why is for yearning to live. It's the will to take back your life from the eating disorder. And I'd like to add a disclaimer. These 8 components of recovery are very different for everyone. Simply because recovery is individual. What worked for me may be completely wrong for someone else. These components of recovery come in time. Unfortunately, there's no schedule as to when you'll hit each one. What I can say is that the longer you stick with recovery, the happier you will be. And now I'm going to transition into an educational PowerPoint from NIDA. It's going to be very clinical. I'm going to try to use layman's terms. All of the terminology comes from the DSM. So what are eating disorders? The most common ones are anorexia nervosa and bulimia nervosa. Binge eating disorder has now been recognized in the DSM-5, and then what used to be called EDNOS, which was eating disorder not otherwise specified, has been changed to other specified feeding and eating disorder. Anorexia nervosa is characterized primarily by self-starvation and excessive weight loss. A very large misconception with anorexia is that people with anorexia hate food. The truth is that people with eating disorders do not despise food. They love it to the point that they are afraid of it. The health consequences. In anorexia nervosa cycle of self-starvation, the body is denied the essential nutrients it needs to function normally. Thus, the body is forced to slow down all of its processes to conserve energy, resulting in serious medical consequences. These include an abnormally slow heart rate and blood pressure, reduction of bone density, severe dehydration, muscle loss, dry hair and skin, and it's very common for hair loss. Bulimia nervosa. The big key component to understand the difference between bulimia nervosa and anorexia nervosa is bulimia is has a cycle of binge purge. People with anorexia can also use the purging behaviors, which includes laxative abuse, diuretics, diet pills, compulsive exercise, and self-induced vomiting. But what makes them different than having bulimia is the binge purge cycle. And binging is eating an abnormally large amount of food, ranging from 1,000 to 3,000 calories in one sitting. The health consequences of bulimia. The recurrent binge and purge cycles of bulimia can infect the entire digestive system and can lead to electrolyte and chemical imbalances in the body. It could affect the heart and other major organ functions. An electrolyte imbalance is really the big thing that doctors are most worried about because that can affect the heart and cause permanent damage. What they check for is the sodium and potassium levels. From the purging, you can get a rupture in your esophagus. You can also have gastric rupture in your stomach from binging, tooth decay, and chronic irregular bowel movements. And then binge eating disorder is a type of eating disorder characterized by recurrent binge eating without the regular use of compensatory measures to counter binge eating. So what's different from binge eating and bulimia is bulimia you will have the purge after the binging, where binge eating you're simply struggling with the overeating. And the health consequences of binge eating disorder include high blood pressure, higher cholesterol levels, heart disease, a risk for type 2 diabetes, gallbladder disease, and musculoskeletal problems. And then other specified feeding and eating disorders include atypical anorexia nervosa, subthreshold bulimia nervosa, subthreshold binge eating disorder, purging disorder, and night eating syndrome. What makes these different from the first three is they're not as severe. Unfortunately, the DSM has specific criteria, and sometimes it can be very messy on how to diagnose somebody. So if their weight isn't quite below normal, they'll be more anorexia nervosa and things like that. It just depends on the severity of the disorder. And then I'm going to go back to my little blurb. Going along with Nita's theme, I had no idea. I'd like to talk about the misunderstandings of eating disorders. Typically, when someone mentions the word eating disorder, we all have an image that pops into our head. What many people misunderstand is that more often than not, eating disorders are an invisible illness. So many people suffer in silence, and no one addresses it because they just don't look sick. I was a victim of this stigma. No one knew about the hell I was going through until I told them. And when I did, I was shrugged off by the uneducated. The only reason I was able to get the level of care I needed was by finding a treatment team who advocated for my health even when I didn't want to anymore. I was in denial of ever being sick because I didn't feel I looked sick. But I am extremely thankful to my treatment team for getting me into a higher level of care when they did, because otherwise I may not be here today. I encourage any one of you, if you or someone you know is struggling, please do not wait until you think you look sick, because first of all, you're never going to think you look sick enough, and secondly, it may be too late by that point. Eating disorders are mental illnesses with physical consequences, and the longer you're engaging in the ED behaviors, the worse the damage will be, and the harder it will be to overcome. And then this slide is just wrapping up everything that we've said. It's the cycle of eating disorders. And as that thing said, the factors that contribute to eating disorders are psychological, biological, interpersonal, and social, and I'll go into more detail in the following slides. The psychological factors have to do with your cognitions and your emotions. So what that means is your thoughts and feelings. Your factors would be a low self-esteem, feelings of inadequacy or lack of control in life. I know personally, when I would use certain behaviors, it was because it gave me a sense of control when I felt like my life was falling apart. Depression, anxiety, anger, or loneliness. The biological factors, this slide is very technical and it's a little wordy. But basically, the main components of it is that there are genetic components. And if you have a family member who has struggled with an eating disorder, there is a higher likelihood that you too will struggle with it. The interpersonal factors are how one interacts with their day-to-day friend group and social circle and family. So interpersonal factors can be a troubled family and personal relationships. Maybe you're just not having healthy relationships or don't have familial support. Difficulty expressing emotions and feelings. History of being teased or ridiculed based on size or weight. And history of physical or sexual abuse. And then social factors, so this is the bigger picture. It differs from interpersonal relationships because it is society as a whole. So body dissatisfaction and drive for thinness are significant risk factors for the development of eating pathology and eating disorder behaviors. Very clinical wording. So basically this is just talking about like how the media portrays women. Even men can get eating disorders as well. So just the constant, like the magazines, just a reminder that they aren't real. And then these are some of the warning signs of anorexia nervosa. As we stated before, dramatic weight loss, preoccupation with weight, food, calories, fat, grams, anxiety. This is more than just like, when people hear the preoccupation, they said, yes, they count calories, but it's even more than that. People will go as far as to limit themselves certain amounts of things per day. There'll be consistent excuses to avoid meal times or situations involving food. Withdrawal from your usual friends and activities. It's very common for people struggling with an eating disorder to isolate themselves because they're very ashamed of what they're going through. The warning signs of bulimia nervosa. They'll have frequent trips to the bathroom after meals. Excessive, rigid exercise regimen. They will exercise no matter whether they're feeling sick or if they injure themselves. There's a possibility that they're skipping class to go to the gym. And discoloration or staining of the teeth. And withdrawal, as I said before, the isolation. And then in severe cases of purging, there can be calluses on the back of the hands. And then the warning signs of binge eating disorder. They'll be very secretive, and they may even steal food. Repeated episodes of dieting or attempts at weight loss. Uncomfortable fullness. They'll constantly be full. Large amounts of food may be missing, and larger than normal amounts of money is spent on their food. And then warning signs of other specified feeding or eating disorders. They'll have very similar warning signs as the other three, but they will just be not quite as severe. Eating disorders are very serious and life-threatening, but they are treatable. Eating disorders are they have the highest prevalence rate among all mental illnesses. And what this slide talks about is that while it has the highest prevalence, it is the least funded. I think last year it was 83 cents, so they did up it, but it's less than $1 for funding per person struggling. And then eating disorders among males, as I mentioned, males do get it as well. And what many people don't realize as well, there is often, when a female is struggling, there's a preoccupation with wanting to be thin, and it is so much more than that. That's just how it presents. But body image issues can be more than just feeling fat, even though fat is not a feeling. It can be feeling inadequate, feeling not muscular enough. I don't feel masculine enough compared to my peers. And then another misconception is when eating disorders finally became more recognized, it was considered the rich white girl disease. But what we are now realizing is that the prevalence of eating disorders is very similar among all races and ethnicities. And eating disorders are often not the only thing someone struggles with. There is a high co-occurrence with depression, and that's often caused because of with anorexia, it's caused because you're starving yourself and your brain cannot function properly to have the other emotions. There's also, with obsessive compulsive disorder, a need for a sense of control. Self-harm is very very common. And what also is misconstrued is that it is true that the ED behaviors can be a form of self-harm. I know my therapist had always said that my eating disorder was my self-harm. And then post-traumatic stress disorder, as we mentioned earlier, it is common for some people struggling with eating disorder to have gone through some sort of abuse, whether it be physical or sexual. And if the abuse was very severe and they had never dealt with it at the time, it is very common for them to have PTSD. And then the mortality of eating disorders. Anorexia nervosa has the highest mortality rate among every other psychological disorder. They are very dangerous if left untreated. And then these are just some do's and don'ts on how to help someone who is maybe struggling. I mean, it's very important to become educated, and you're all making a great step in doing that today by attending this speech. And be very honest with them and vocal about their concerns. Do not look the other way. If you notice them slipping or you notice some of the behaviors, try to find a way to address it with them in a non-threatening way. Compliment their inner qualities. Tell them how smart they are. Tell them how caring they are. Tell them how creative they are. Don't constantly say you look thin or things like that. Be a good role model. Practice what you preach. If you're going to tell somebody to pick up the fork, don't be looking at the magazines for the next diet trend. And tell a trusted adult if there's something you can't do. And then there's different treatment for eating disorders, and this is the levels. This is the breakdown on how to do it. I mean, as we just said, it's very important for intervention. The earlier you catch on to it, the faster is not the correct word, the more successful they will be. Professionals, there can be a very key role. Because eating disorders are so complex, it is important to have a team I see a dietitian, a psychiatrist, and a therapist. And I know people who see even more than that. It's typically you'll want to have a PCP as well, a primary care physician, to do labs and blood work to make sure you're on track. And you need all of those components because eating disorders attack every aspect of your body. And then it's important to have support. Try to be there for someone. Do what you can, but know your boundaries as well. Because recovery is possible. And then seeking treatment, as I just went over. You'll want to meet with a medical professional. You'll want to have a therapist and a dietitian to help with your nutrition needs. And these are just some different levels of care, and I will go into more detail in the following slides. Residential treatment is very different from inpatient treatment. Residential is not a hospital setting. The patient will reside there. They will stay there. And they will have constant observation during meal times. And they will have a therapist and everything like that. But they need to be medically stable. These patients that go to residential will typically not be severely underweight. And their labs won't be critical. Now, inpatient treatment is for the people who need a more medical observation. That is in a hospital setting. But they do a lot of the similar things that they do at a residential. It's just in a hospital. Then there's a partial hospitalization treatment. This is typically a step down from either residential or inpatient treatment to adjust back into your normal everyday life. And it can also be for people who are early in the recovery if you caught it in time and they didn't get severe enough. If they weren't as severe to need inpatient treatment or residential treatment, which is great, then they can go to the partial hospitalization. And then the next step would be intensive outpatient or outpatient treatment, which is typically another step-down program. I know the program I did, I was in inpatient, and then I did the partial hospitalization, and they wanted me to do IOP, but I had already been seeing a therapist enough that I felt I was ready to go on my own. And NEDA does have some resources on their website as well stories of hope if you're looking for inspiration. And then, for those of you who aren't aware of what NEDA does, NEDA is the National Eating Disorder Association, and they support individuals and families affected by eating disorders and serve as a catalyst for prevention, cures, and access to quality care. And then here is some information and a referral helpline. I can go back up to this at the end if anybody needs it. Something I really want to talk about is the NEDA Navigators. This is a service I have used myself. It is somebody who has either gone through an eating disorder, has had a loved one who's gone through an eating disorder, or is a professional that is able to deal with it. And they will email you about, I think mine did it about once a week, to just talk and give you any resources they can. And it's completely free. And then NEDA does have other resources as well to find a treatment center, or they have a helpline. Now, I'd like to conclude with recovery has been anything but rainbows and ponies. But what I can say, it is so much better than continuing my life in the throes of an eating disorder. To be completely honest, I still struggle to face the mirror every day. There are days that picking up the fork just doesn't seem like an option. And during these times, I am reminded that I am not doing this alone. I have utilized the free NEDA Navigator service, and one of my biggest supporters happens to be the girl I booked to speak at Teal College last year. I have a fantastic therapist and dietitian who remind me that recovery is my only option, and thanks to recovery, I have the support of a wonderful man who not only wants what's best for my health, but doesn't question me when I fall apart. I also was blessed with an amazing little sister in my sorority who didn't disown me when I had to take a 2-month leave of absence, but rather called me nearly every day and welcomed me back with warm and open arms. And with this, I'd like to leave you with a quote from philosopher Jean-Paul Sartre. "Freedom is what you do with what's been done to you. I used to find it so easy to question the universe about the cards I've been dealt, but the questioning never led to anything. One day I realized that I'm not alone in my struggles, and so I decided to advocate for them." Thank you.
All right, thank you everyone for coming out.